Okay, welcome to Pediatric Grand Rounds, everybody. I'm pleased to introduce Dr. Rosanna Wustrack today, who is Professor of Orthopedic Surgery and Chief of Orthopedic Oncology here at UCSF. Dr. Wustrack completed her surgery residency, orthopedic residency here, and then did a fellowship in musculoskeletal oncology at Sloan Kettering. She's a member of the UCSF Sarcoma Center, and her clinical practices focus on treating musculoskeletal tumors and fragility fractures. And as well, she does research dedicated to improving functional outcomes for cancer patients. Today, she's going to update us on her work related to reconstructive techniques and rehab for pediatric extremity sarcomas. And it's a great pleasure to introduce Dr. Wustrack. Welcome.
Thank you. Thank you. Thanks so much for having me. These are your upcoming presentations. I hope you guys can all make it. All right, so I did want to talk a little bit about the evolution of endoprosthetic limb salvage surgery for pediatric extremity sarcomas, go over some of the successes in the field, some of the failures, and where we have to go. And if I can get through this and we have some time left, I'd like to talk a little bit about something I'm interested in, which is sarcoma immunotherapy. So I have nothing to disclose that's relevant to this talk, except maybe the fact that I am an orthopedic surgeon. So I think X-rays are maybe the most fascinating things to look at on a slide, and that might not be shared by everyone here, but we'll get to it. So I'm going to start this talk with a case, and this is actually a patient that I think both Cindy and Tracy took care of. So she presented when she was almost 9 years old, very active little girl, really felt that she was headed towards a professional tennis career, really athletic, really active. Felt fine, no problems, fell off her scooter and had excruciating pain just above the knee and swelling. That pain got better over the next week, week and a half, but the swelling did not. So her parents made an appointment with her pediatrician, went and saw her pediatrician on a Thursday. Her pediatrician got these x-rays. So what I always teach our orthopedic residents, and hopefully there's some learners on the Zoom and would like to teach you, is we can actually get the diagnosis just from these x-rays. So first of all, you're all probably looking at the x-rays and right away you can say, that's not normal. That is not a normal bone. I'm no orthopedic oncologist, but it's not a normal bone. And you can see that there is something in the distal femur. Now, what I tell the residents is we have to look at three things to make the diagnosis. The first is, can you draw a line around that abnormal area? In other words, is it growing so slowly or not growing at all that the body can wall it off? Can I easily say this part's abnormal and this part's normal? Well, you can't, right? You can see that at the top of the femur, that looks pretty good. Down at the bottom, that looks really bad. But where is that transition point? The fact that you can't see it makes you think, oh gosh, this is probably aggressive. Okay, secondly, the bone, and some people might say orthopedic surgeons also, is not so smart, not so sophisticated. The bone has one tool to fight every problem: infection, it's broken, tumor. All the bone can do is make more bone. So when you look at this, again, if you look at the image on the right side, your left, you can see that there's some new bone being formed outside the original footprint of the bone. That's the body saying, oh no, this is bad. Let me try to contain this. And that's called a periosteal reaction. So now it's the second thing that tells us this is aggressive. I don't know where it ends, and the body is trying to contain it, but failing. 2 strikes. Then we have to look at this abnormal area and say, well, what is it making? Is it making cartilage? Is it making bone? Is it not making anything? So we look at it and we say, okay, it's a little bit more white than the rest of the bone on the x-ray. It's radio-opaque. That is osteoid. So now we've got this aggressive appearing bone lesion, bone growth, making bone. What is it? It's an osteosarcoma. Like, we know that. Now we still have to do all the studies, but the pediatrician saw this, the pediatrician knew this, and got the patient in to see my colleague, a pediatric orthopedic surgeon, on a Friday. He was able to get an MRI on a Saturday. And the MRI, interestingly, doesn't actually give us much more information than the x-ray, right? We already know this is scary. This just sort of tells us maybe how scary it is, right? So we have to do a biopsy. We do that on a Tuesday. And the biopsy in this case confirms what we already know. If you look at the histology here, you see a lot of ugly cells and they're trying to make bone. So the pink stuff is new bone. It's really disorganized. It's immature bone, and all those cells in the background are super ugly. So now we've got a malignant mesenchymal neoplasm making bone. It's osteosarcoma. And fortunately, we get staging studies. This was 2015. We got a whole body bone scan and a CT chest, no disease anywhere else. So now we've got a 9-year-old girl. So we've got a growing child with localized extremity high-grade osteosarcoma. So as a team, we come together. We have just the most amazing sarcoma team here. Love seeing some of you here in the audience. And we come together and we say, well, what's the right treatment for this patient? Well, we know that multi-agent chemotherapy, that is the game changer. And I'll get to that in a minute. But now what about local control? What's the role for local control and what options do we have? And that's where I come in as an orthopedic oncologist. And for me to really make a good recommendation, I need to know what's her prognosis, what are her goals, what are her family's goals, what are their priorities, and how can we balance the short-term and the long-term risk, benefit, function, durability to give her an extremity, her native extremity or prosthetic extremity that's going to fulfill her goals and give her the best function moving forward. So today, that's sort of what I want to look at. I want us to review some of the historic treatments of primary bone sarcomas, primarily osteosarcoma. And I want to talk about the major advancements, both in treatment and technology, that have influenced our limb salvage options today. We'll briefly touch on systemic treatment, imaging, and implant design as it relates to endoprosthetic reconstruction. And then I would really like to let you guys know what we've done at UCSF that's really moved this field forward. So osteosarcoma, as you know, it's the most common primary bone sarcoma, and the peak incidence is really in the teenage years. This is really when people are at maximum growth, and that's when we see these osteosarcomas occur. And while it's really rare, they make up maybe 2% of pediatric cancers. And the most common location is the distal femur, followed by the proximal tibia and the proximal humerus. We also occasionally see it in the pelvis, the mandible, and the ribs. So what did we do? What did we do before you guys, before chemotherapy? So in the pre-chemotherapy era, this was 1940s, 1950s, 1960s. Treatment was ablative surgery. So what do I mean by ablative surgery? I mean high-level amputations. So if our patient presented exactly as she had in 1960, 1955, she would have gotten high-dose radiation to the distal femur, probably up to 70 gray, to just kill the tumor, and then she would have had a hip disarticulation or an amputation at the level of the hip. And her 5-year survival with that really aggressive local control would have been 20%. So this is a good reminder to the sometimes not so humble orthopedic surgeon that you cannot cure osteosarcoma with surgery. It's not a surgical disease. So this was just a nice paper looking at the Memorial Sloan Kettering experience in the pre-chemo era, 20% 5-year survival with crazy surgery. So as a surgeon, before we can even think about limb salvage, patients need to live. We need more than 20% of patients living 5 years. And so the biggest advancement, of course, in treatment for osteosarcoma is chemotherapy. So in the 1950s, 1960s, antifolate chemotherapy was starting to be used for leukemias. And Dr. Jaffe was a fellow at the time, and he noticed that methotrexate was having a really good survival effect on Wilms tumor. And he started to think, well, could we use this for osteosarcoma? So he began using high-dose methotrexate to treat osteosarcoma patients. And he published on their own series and found really good outcomes. So this survival curve here, so if you look at the solid line, that is their historical controls. And it really mirrors what I showed you 2 slides before, right? About a 5-year, 20% survival rate. Those were the historical controls. Then he had a group of 32 patients that were treated with chemotherapy with high-dose methotrexate. The top line that had 100% 18-month survival, that was a group of 12 patients that had negative margin surgery. So they had a resection and they had negative margins. Those 12 patients were alive at 18 months. The second line, the dashed line, the shorter dashed line, that's a group of 20 patients. They received chemotherapy, but they had positive margin resection. So this was very compelling data that chemotherapy is kind of flipping that curve a little bit, but there were naysayers, and I'm not going to name any names, but there were naysayers that said, you know, we need a randomized control trial. We need to know this really works. So in 1986, this study was published in the New England Journal of Medicine, and it was a prospective randomized control trial. 18 patients received adjuvant chemotherapy, 18 patients were controls. And I think it's pretty clear that chemotherapy works. A lot of criticism for this paper though, right? 18 patients were randomized to receive no chemotherapy. 50% of the patients had thoracotomies. Chemotherapy was not widely adopted until this paper was published and probably delayed the rollout of chemotherapy by 5 or 6 years. But a landmark paper really changed the paradigm. So now we have almost a reverse curve, or approaching a reverse curve, we hope. This is a study that looks at 10-year overall survival rates by decade. And in the 60s, 10% 10-year overall survival, major jump with chemotherapy, and a flat line. So good news, bad news. It is not improving. It's been about 45 years that we're kind of at the same place, and we haven't really been able to find new and novel agents to treat the 40% of patients that are not surviving to 10 years. Okay, so that was my point. All right, so back to what I do, back to thinking about limb salvage surgery. We know it's not the big piece of the puzzle, but it is a piece of the puzzle. And we know that in order for these patients to get a cure, they do need a negative margin resection. They need good local control. So after chemotherapy, the next major technological advancement was the MRI. This is a picture of the first human to go through a full MRI in 1977. Anyone want to guess how long that took? 5 hours. So I feel that our patients are like, oh my God, I don't want to be in the scanner for 45 minutes. Like, no, it was 5 hours. But this is a game changer. So think about this from a surgeon's point of view. I know I need to get negative margins. And if I don't get negative margins with my surgery, it's going to be a bad outcome for the patient. And I may take a patient who could be cured to not cured. But without an MRI, I really don't know where the tumor ends. I don't really know what is going to be part of my margin. So the advent of the MRI really made limb preservation surgery possible, because the surgeon can now understand what is involved in the soft tissues. Are the vessels involved? Are the nerves involved? Is there a skip lesion in the femur? All these things are really important to determining, how am I going to get this tumor out? How am I going to get good margins? Without good cross-sectional imaging and without the MRI, you're kind of flying blind. And then an amputation through the hip just seems safer. You know, we're talking about someone's life. So lastly, implants. So in the 1970s, primary total hip implants were being developed, and they were being adopted in Europe and the US. So in the 70s and the 80s, we were starting to adopt these metal implants. This is an endoprosthesis, metallic endoprosthesis. And we were now being able to make them in a custom sort of 1-by-1 fashion. to replace that large bony defect from the resection. So these are the first generation metallic endoprostheses, primarily for cancer patients. So has anyone ever wondered why, when we're giving someone chemotherapy for osteosarcoma, they get 12 weeks of 10 weeks of neoadjuvant chemotherapy, then they sort of get their counts up and they magically have surgery around 12 weeks. Has anyone ever wondered why? And then they get some random number afterwards. Why is surgery at 12 weeks? This is why, because it took 12 weeks to make this implant. So someone would come in, they'd be diagnosed with osteosarcoma. The surgeon would say, I can save this patient's leg, just give me 12 weeks. And it's like, and do what? Let's give them chemotherapy. So that's where this idea of 12 weeks of neoadjuvant chemotherapy, local control, and then adjuvant chemotherapy came up. There's some interesting papers out there. One I thought was most interesting where all patients received 40 weeks total of chemotherapy. Half received that 10-week local control, 30 weeks, and the other half got all 40 weeks adjuvantly. No difference in survival. So it's not really a survival advantage. It does give us good information about how well that chemotherapy is working, but it's kind of just a holdover from when it took that long to make the implants, which I think is kind of interesting. So now that we've got good chemotherapy, so now we're in the 80s, we've got peg leg jeans, bell bottoms are out. We're loving Miami Vice, we're in the 80s. We've got really good chemotherapy, game changer. We've got imaging, so we know where the tumor is and where the tumor is not. And now we have implants that we can use and we can get people up walking around on these implants. Now limb salvage is a viable option. And this was a multi-center retrospective study that looked at over 200 patients. All these patients had distal femur osteosarcoma, and they looked at the overall survival between those that had through the hip amputation, above the knee amputation, or limb salvage surgery with an endoprosthesis, and there was no difference in survival. So from a surgical standpoint, that changed the paradigm to make limb salvage sort of the primary form of local control for this patient population instead of amputation. And now in 2025, I would say over 90% of all the patients that come through our doors are going to be treated with limb salvage surgery. It's very rare that we will treat patients up front with an amputation, and that's in cases of neurovascular involvement. And we unfortunately do still see that, but most of the time we're able to start with limb salvage. Okay, I'm gonna take a little quick sip of my water. Any questions so far?
I may have missed it, but does limb salvage versus not limb salvage impact mortality, like within the survival rate?
No. So this was that retrospective study. This is looking at overall survival. No difference in overall survival from amputation or limb salvage surgery. There is maybe a slight difference in local recurrence, but no difference in overall survival.
This is with the chemo.
Yes, with chemo. Sorry, with standard chemotherapy. Sorry. All right, so then when we are talking to patients about the local control surgery, it's really important that we keep in mind that we do need to get a negative margin. The most important piece of the puzzle is the patient's life. It's the one instance where we as surgeons can participate or contribute to a cure. And then we think about function, and then we think about cosmesis, and sometimes families come in and it's a little bit upside down. They're talking a lot about this professional football career that the child was headed to, or, the scholarship that the child was about to get. And we have to kind of really reframe it and say, we're talking about your child's life. So the one thing we have to do is we have to get negative margins. And then we can talk about function. And then we can talk about how that leg's going to appear. And all of these things are important. And it's not to minimize the function by any means, or the cosmetic appearance of the limb by any means, but you do have to have a hierarchy of priorities. And in 2025, there are so many options. We can do an osteoarticular allograft, so take dead bone and put it in the knee. We can do this metal endoprosthesis. That's what we'll focus on. We can do the patient's own fibula, vascularized fibula that you can see here. That's the fibula from the other leg. We can do something called bone transport, where we move their own bone slowly to fill the gap. We can do a rotation plasty. I mean, there's so many things. And it's really depending on the patient, the age of the patient, the location of the tumor, and the goals of the family. But me personally, I feel that the most reliable, surgery I can offer that I can really have some data around to tell the family what to expect is an endoprosthesis, although I will do all of those and, depends on the patient. But what's really nice about it is it's modular. It's currently off the shelf. It's very good for metaphyseal defects, which is the most common location for osteosarcoma. Patients can get up and walk around early. There is a method to lengthen the metal implant so we can get equal leg lengths at skeletal maturity. And the early complications are few. And the reason why that's important is because we need to get those patients back on chemotherapy. So we do want to offer something that we can reliably get patients back on chemotherapy within 3 weeks. And sometimes the crazier out of the box surgeries, you just can't rely on that. And there's a much higher risk of wound complication and delay in chemotherapy. So this is just more predictable and versatile. Okay, raise your hand if you know who this gentleman is. So this is my former senior partner. He retired maybe a year and a half ago, Richard O'Donnell. He had this great saying, which was, beware the long arm of limb salvage, which is really true. So this is actually an x-ray of a patient of mine that I put in these bilateral distal femur cemented endoprostheses, and they both failed. So, these implants have lots of problems, and we'll go over that. So the most common problem we see with the first generation endoprostheses is something called aseptic loosening. So these are just different x-rays. Aseptic loosening means no infection, but over time, the cement around the metal loosens. So the way these are put in is you have something called bone cement with this, which is polymethyl methacrylate. And the idea is that the bone cement is going to bond with the bone and with the implant. So it's basically like you're just shooting super glue up the femur, and then you jam in the metal implant. You hold it there for what feels like an eternity, but is actually usually around 9 minutes. You just hold it there until it hardens. And then it's like, great, good to go. Well, of course, polymethyl methacrylate is not living. Metal's not living. And every time you walk, it's a little bit of a stress. It's a little bit of stress. And so over time, you will see loosening. And the loosening can either be between the bone and the cement or the cement and the metal. And that's called aseptic loosening. And so some of these early studies on these large metal endoprostheses fixed with cement showed that there was a 40% rate of revision at 10 years for aseptic loosening, which is pretty unacceptable. So now we've got our 9-year-old, and she's 19. She's in her freshman year of college, and we're going to do a huge revision surgery. So there's definitely was a need for improved anchorage, or how do we get that big bulk metal endoprosthesis to be more firmly secured to the bone and not fail. So this is where UCSF was at the forefront of innovation. So the gentleman in the upper left corner, that's Dr. Jim Johnston, just an amazing educator, an amazing orthopedic oncologist. Everyone actually called him Yoda because he was just so wise and talented and such a great teacher. And then below him is a gentleman named Dan Martin, who was an orthopedic resident at UCSF. And together they came up and popularized this new device that secured the implant to the bone. And it's very cool if you're an orthopedic surgeon, and I'll try to make it interesting if you're not. But the idea is, are you guys familiar with something called Wolff's Law? So Wolff's Law is the concept that your bone responds to force. So if anyone has elderly parents and they've got osteopenia, osteoporosis, and you say, Mom, you need to do weight-bearing exercises. Swimming is not enough. Biking is not enough. You need to be loading your bone because that's how your bone's going to remodel and make more bone. That's how you get more bone density, is by the bone seeing force. The way this implant works is you cut the bone and then you basically push this hydroxyapatite coated platform onto that bone and you load it with 800 pounds of force. So I'm going to try to yell so the webinar can hear this, but I'm just going to point over here. So right here, this is the platform. It's got hydroxyapatite coating and it's very porous. It has the same geometry as bone. And then you've got these stacked washers and you tighten this nut and it results in 800 pounds of force going against the bone. And then the bone sees that force and the bone sees this force and it responds by making more bone, which you can see here. Do you see how the bone is flaring out? That is the bone growing into the implant. And like I said, that platform has this three-dimensional geometry that allows the bone to grow into it. And once you see that, we call that an elephant's foot. Once you see that junction is pretty much stable for life. And so this is called osseointegration. And Dan Martin developed this because he wanted to make a ton of money and he was hoping everyone would adopt this for primary total knees. And no one was interested in this for primary total knees, literally no one, and they still aren't. But Dr. Johnston, who was a tumor surgeon, said, actually, this aseptic loosening is a huge problem. All we have right now are these cemented implants and they fail. I'm interested. So then those two kind of worked together. They had a sheep study. They put these implants into 5 sheep, looked good. All 5 sheep healed and they were like out in the paddock doing great. And the FDA was like, sweet, great. It worked in 5 sheep. Go for it. So like the 80s, the 90s. I mean, it's so wild. So they did this sheep study. I think that was 1990, 1991. And then the first one went in a patient in 92. Anyway, couldn't do that now. But it is really interesting. And I had the chance to speak to both of them. And the biomechanical science behind this is really cool when you talk to Dan Martin, and it truly works for this purpose. So this is actually the implant of choice that we use here at UCSF. So you may see x-rays that look like this, and it's really powerful. There is a much lower risk of that aseptic loosening. You can use it for these short segments when there's not a lot of bone left, and it makes revision surgery much easier. Dr. O'Donnell, and this is Dr. Laura Randall. Laura Randall's an orthopedic oncologist at Davis. He's a member of COG. He might even be at COG right now. Together, they've done a bunch of different studies. And what we found from all their early studies is there's a low rate of failure. Once you get that good bone ingrowth, which usually happens within 2 years, it's unlikely to fail. And patients do best at the proximal femur, followed by the distal femur, followed by the proximal tibia. Okay, so that's the implant we like. That's why we like the implants. What about kids? Can we use this implant in kids? Well, kids are really tricky because the osteosarcoma tends to affect the area of most rapid growth. So if you look at my little diagrams here, again, the distal femur is the most common location for osteosarcoma, tends to occur in kids right around puberty or their teenage growth spurt. And the most active growth plate in the body is the distal femur growth plate. So you wipe out the distal femur growth plate, that's definitely going to set up a child for a huge leg length discrepancy at skeletal maturity. And that diagram in the middle is really showing us the average growth around the knee versus the hip versus the ankle. And you can see that the vast majority of the growth is around the knee. And if this is the implant we're using, what do you think that does to the growth plate? It's pretty damaging. Okay, so back to my patient. So what are we going to do for her? Budding tennis superstar, Lovely family, lovely patient, localized disease. We're aiming for a cure. So we talked about everything. I even made them an Excel spreadsheet with each option and like the pros and the cons. And after back and forth, they decided on a metallic endoprosthesis that allows for growth. So do you see that part right there? I'm going to walk over it. So that is the part of the implant that lets you lengthen it. So you can turn a screw around the knee and it basically lengthens the implant, and each revolution lengthens it about 1/10 of a millimeter. So you do 142 revolutions and you get a centimeter of length. And so this is a way that we can lengthen patients over time. And this is how she looked maybe 3 to 6 months after surgery. I want you to keep your eye on this. See how there's no bone growth there because we just put it in? But this is how she looks over time, same patient. Look at that bone growth. That's that compress. And then that white arrow in the middle panel is showing how we've lengthened her. So at this point, we've gone to the operating room about 3 times. Every time we go, we lengthen her 1 centimeter, but then it collapsed. So that lengthening broke. And you can see we had to do a big revision. Fortunately, she's doing great. She's now a sophomore in college. She golfed for her high school team. But this is just an example of how, as much as we pat ourselves on the back, they're just mechanical objects that can fail. But this led us to form a study group. So this is a group of 5 institutions. All of us are orthopedic oncologists, and all of us primarily use this implant. So we decided to pool all of our data so we could ask some questions about how this implant works and how it's functioning and what improvements we can make. So that's our UCSF group. Dr. Melissa Zimmel, my partner, myself, Dr. O'Donnell, who retired, Kara Tanaka, who worked with us as a medical student, is now a pathology fellow. In the middle is Keontae Murray, current partners, and then 2 of our medical students on the bottom there. And then we have the UC Davis, the Stanford, the OHSU, and the Kaiser group. So we all work together and we ask the question of how do pediatric patients do with this implant, and how well does it osseointegrate, and how often does it fail? So this was led by Kara when she was a medical student, and then we got data from all of the institutions, and we wanted to look at pediatric patients with distal femur primary bone sarcomas and understand how they did at minimum 2-year follow-up. And what we found was the survival curve on the left, that's showing that bone implant junction, what we've talked about. Those do really well. So that kind of mirrors everything else we've seen. There's maybe up to a 10% failure there, but once it heals, it doesn't fail. But look at that survival of that expansion. So when that failed, the implant rep from the company said, we've never seen that. It's like, really? You've never seen that? No. I said, well, didn't that happen to Dr. O'Donnell a few years ago? I don't know. So it actually happens a lot, right? So this is an unacceptable rate of failure for that internal expansion mechanism. So because of our study, they took the implant off the market for about a year and a half, and they redesigned the expansion mechanism, and now it's back on the market. We also wanted to look at what other problems, because I think one of the biggest problems we as orthopedic surgeons do is we're so implant focused. You know, we think of, well, how did the implant do? Did the implant survive? Did the implant grow into the bone? But we don't think enough about what is the patient going through? How many unexpected surgeries did the patient have? And so what we found is even when the implant did well, there were all of these different problems that the patients faced. So in 36 patients, 20 of them had some sort of unexpected complication or return to the OR for infection, for stiffness, for a local recurrence, all different things. And so 81% of patients had some complication, some unexpected problem. Another thing that we've popularized here that's very novel is doing this proximal tibia hemiarthroplasty. So again, when we have patients that have a proximal tibia osteosarcoma, we're trying to think of ways that we can save that distal femur physis, or the growth plate in the distal femur. And one way you can do that is by just replacing the tibia, and then you're set up to do a total knee down the road. It's kind of a temporizing thing to get patients to skeletal maturity, and then you can very easily resurface the femur and give that patient the hinge total knee. And this has worked very well. And lastly, this is another one of our medical students. She's now an intern here at UCSF in internal medicine. I feel like I have not the greatest track record of publishing with medical students and then they don't go into orthopedic surgery. Matilli, don't take any notes. You stay in orthopedics. But we kind of showed the exact same thing. We keep showing this again and again, which is that bone junction does really well. But half of our patients have to have an unplanned revision at 10 years. And so that's pretty unacceptable. So why is that? It's because these, like what I tell patients is, do you ever take a paper clip and you go back and forth with the paper clip, and then ultimately the paper clip breaks? Like, the paper clip will break 100% of the time. It's just a matter of how many times you bend it. So you can think of these implants as huge paper clips. They're not biologic. They're subject to fatigue failure and different mechanical failure, and unfortunately, and probably most importantly, infection. So this was a really interesting study that reviewed all the endoprostheses done over the past, I think, 20 years from 5 institutions. And they just tried to figure out what is the indication for revision of the metal endoprosthesis. And they put them into categories. So local recurrence was one, soft tissue failure was one, fracture was one, the mechanical failure, and infection. So type 4 is infection. So the most common reason we have to take patients back to the OR is an infection. So we've got the bone part figured out. Now we need to figure out the infection. So this is a number that I think might be helpful for anyone that sees our patients, just to keep in mind. This was a really well done prospective randomized trial. It was an international study. 48 different institutions contributed patients. They were all cancer patients that were treated with a lower extremity endoprosthesis, ages 12 and up. We had 8 patients from UCSF that were part of this study, and patients were either randomized to 24 hours of Kefsol around surgery or 5 days, because the common practice is we just keep patients on antibiotics forever because we're so afraid of an infection. And it turns out there was no difference in the rate of infection. So we really should just be doing 24 hours of infection, because the rate of C. diff was higher than the 5 days. But also, I think what's really important is the rate of infection is really high. It's 15 to 16% of these patients are going to get an endoprosthetic infection at 1 year. And that number just rises with time. So it's a big problem that we'll come back to. And then the last thing I wanted to say before we shift gears is, I told you earlier, probably more than 90% of our patients that come through our door, we're going to treat them with limb salvage surgery. But this was one of our residents, and he's gone into orthopedic oncology. He's now at Miami. He and I wondered, but how many people get a late amputation? You know, what can we tell patients about their risk for an amputation after limb salvage surgery? So this was a really interesting study, and Rob Goldsby helped us do this. We used information from the Childhood Cancer Survivor Study, which is a huge longitudinal study out of St. Jude's. Basically, to be enrolled in this study, patients have had to have survived any childhood cancer for 5 years. Once they're at 5 years, then they are can be enrolled in the study. and they're sent surveys once a year. And so they answer a lot of health-related quality of life questions, but also, have you had any surgeries in the past year? What was that surgery? So that's the data we used, and we looked at sarcoma patients and lower extremity limb salvage patients. And we found that the rate of a secondary amputation, so an amputation after 5 years, when we looked at all comers, was about 18%. So about 18% of patients need an amputation after a successful limb salvage surgery. So after 5 years. The good news is we found that the rate was highest for the cohort of patients that were treated in the 70s and lowest for the cohort of patients that were treated in the 90s. So there have been improvements, and probably that's improvements in surgical technique, chemotherapy regimens, and things like that. But it is a really big problem. And we need to tell people that, which we don't, because it's so overwhelming. They just got told they had osteosarcoma, and now you're going to tell them you're going to do a huge surgery, and feels a little awkward to then say, and then in 5 years you have an 18% risk of an amputation. But we do need to make sure people understand the whole scope of the problem. So kind of in summary, when I think about a patient coming through the door, they've got their extremity osteosarcoma, and we're talking about how to take out the tumor, and we talk about limb salvage. We need to be honest about the trade-offs. So it's a great way to preserve the limb, but it won't last forever. I do tell patients, especially pediatric patients, for sure you will need a revision at some point. Like, our goal is that you're going to live till 80 plus. Between 12 and 80, you are going to have some revision, probably many. We can get leg length equality. They can walk quickly. They can get back to chemo quickly. There's a low rate of early complications, but a high rate of long-term complications. And we really don't have any good solutions, sorry, as of now, 2025. So in summary, I would say thanks to the progress in systemic therapy, imaging, and biomechanical technology, we can offer patients limb salvage surgery, but there's pluses and minuses. And as Dr. O'Donnell always said, beware the long arm of limb salvage. Fortunately for him, he retired, so I have inherited his long arm of limb salvage. And implant infection is a problem. So got like 5 more slides. You guys doing okay? All right. Okay. So this is just talking about implant infection. I just want to talk a little bit about sarcoma immunotherapy. So is the father of immunotherapy. So he was an orthopedic surgeon. He practiced in the late 1800s, early 1900s. And when he was a second-year resident, he had witnessed that a patient that had, a sarcoma in the neck had gotten a really bad strep infection. So they had done surgery, and then the patient got a bad strep infection and then did really well. And so the tumor completely regressed. And so he was very curious about this and was wondering, was the infection, did that cause the tumor to regress? So he was at New York Hospital at the time, which is Memorial Sloan Kettering now, and he went through all the case files, and he actually found 7 other cases that were really similar, where patients had a post-operative infection or a post-biopsy infection, and their tumor regressed, and they were long-term survivors. And then he even found this patient that was 7 years out of this infection, and he was living in New York, and he went and found the patient and confirmed that he was alive 7 years later after a really bad strep infection. So he thought, all right, now I know the cure for cancer. So he developed what's called Coley's toxin, and he used strep and staph, live strep and staph, and he started injecting patients' tumors with this. And he would do a lot of different things. So it was very heterogeneous how he treated patients. Sometimes he would inject the tumor, sometimes he would inject nearby to the tumor, sometimes he would kind of go in the lymph node bed. A few people died. So then he started using heat-killed bacteria, and that is what became Coley's toxin. He actually did a really good job of taking notes on all of these patients. So he had all these case logs so he could document how well patients were responding to immunotherapy. I mean, this is like 1900, 1910. This was kind of all there was, surgery, and then he had sort of stumbled upon this potential adjuvant, immunotherapy. So, well, what happened? Well, he was at New York Hospital, and William Coley is the father of immunotherapy, and then his boss is James Ewing. James Ewing was cancer man James Ewing, and he was a huge proponent of radiation to treat cancer. And he was funded by a very wealthy railroad magnate who also believed in radiation. So the wealthy donor had given James Ewing all this money to set up a radiation research program at New York Hospital. And so all the beds were designated for radiation, whereas William Coley wanted to do immunotherapy. And so James Ewing said, you will not be allowed to do any of your Coley's toxin at this hospital. And so he had to do his Coley's toxin at some of the other hospitals in New York. And because James Ewing had the money and William Coley didn't, immunotherapy kind of got sidelined at that time. But William Coley really believed in sarcoma immunotherapy, but he didn't understand the mechanism. It was just something that he observed seemed to work. He had a variety of different Coley's toxin. He delivered it in many different ways. It was available on the market. It was FDA approved in the early 1900s. But as people tried to sort of do it themselves, oh, he's got such great outcomes, no one could really replicate his outcomes because, again, he did it in a lot of different ways. And so then the FDA finally made it illegal to treat people with Coley's toxin in the 60s. I do want to come back to this gentleman, Yoda, again. He really believed in Coley's toxin, and he injected his own patients. So he was at Kaiser. He had 7 patients that the first 3, he injected their drainage tube. So he did a sarcoma resection. They had a drain. And he went to the lab. He cultured Staph aureus. He injected it through the drainage tube and waited for them to get a fever. And once they got a fever, then he'd treat them with antibiotics. And then the micro lab said, we are not going to give you any more staph. This is crazy. So then he put his own sputum he told me this himself, put his own sputum. And then the director at Kaiser said, I will report you to the medical board. You will be fired and you will lose your license if you do this. So he treated 7 patients that way. But he also really believed in this idea of, I'm going to skip through some of these, of a bacterial infection leading to a cure. But neither he nor Coley ever really understood sort of the biology and what is happening. It seems that there's a lot of papers on this over the years, and I won't bore you, but it seems, some papers show a really good effect on overall survival in osteosarcoma patients that have a postoperative infection. Some papers show no effect. Some papers show that patients do worse. So I think mostly we'd say some people, the infection does seem to provide a survival advantage, but we don't know why until this amazing person is figuring it out for us. And so it's really fortunate that we're now at a point where we can better understand the interplay between the immune system and the cancer. And we can now manipulate really specific pathways in the immune system that can lead to an anti-cancer effect. And Dr. Young will tell us more about that when she's up here at the podium. But I think this is really exciting work, and it's just building on old knowledge, but finally understanding some of the underlying mechanisms. So I just want to say thank you so much for this opportunity. It's really been a pleasure, and I'm happy to take any questions.
So we have one question online, and I will ask them both. So the online question is, what is the benefit of the device being modular? And that came a little earlier, so I feel like the other stuff we talked about probably. And my question is actually about the later amputations. I might have missed, but what are you gave a lot of information about complications, but what are those things that lead to those later amputations?
Yeah, absolutely. So the first question was, what is the benefit of a modular endoprosthesis? So the benefit of the modular endoprosthesis is that all of those components can be on the shelf. So you don't need that custom implant design. And they come in, 4 centimeter segments, 2 centimeter segments, all the way up to like 10 centimeter segments. The downside is that you've got these points of failure because you can imagine there's a little bit of weakness at the junction of all those modular components, but it just allows more versatility. As far as your question of what's leading to the amputations, when you look at all of these secondary amputations, the number one cause is an infection. So if we look at just patients that have an endoprosthetic infection, about 1/3 of those patients will end up with an amputation despite antibiotics, despite revision surgery. So that's kind of the leading driver of an amputation, followed by local recurrence.
What does that procedure look like for the lengthening? Is that quick, uncomplicated, in and out?
Well, so there's a couple different lengthening mechanisms. The one that I showed here, there is a screw at the knee, and you make about a centimeter incision and you insert a screwdriver, and then you rotate this worm gear mechanism that then sort of ratchets up the telescoping part, and that's how you get the lengthening. But there's a better implant on the market where they use a magnet. And so it's not surgical. You do it in the clinic, and you can do 1 millimeter, you could do 5 millimeters, you could do 3 millimeters and bring the patient in like once a month. And so then you get a much more gradual leg lengthening. But unfortunately, that company has a different way that it marries to the bone. So what we're hoping for is that we can incorporate those two technologies, that we could use the compress anchorage with that magnetic lengthening, but it's definitely much better, lower rates of infection.
I have a not very well formed question because I'm trying to digest all of the information. There's two things that puzzled me a little, or not puzzled, but surprised me a little bit. One was that you showed that since in starting chemotherapy, in the 70s or so, and the 2000s, survival rates really haven't changed. And I assume people keep on trying new regimens like they do in other cancers, right? So I was like, oh, that's actually surprising me. And then the fact that limb salvage versus resection really doesn't
versus amputation.
Amputation, yeah, sorry, that's what that really doesn't matter. But those data are from the 80s. So I was just sort of like, so the 40% that are 10 years, so that die by 10 years, right? Like, is that recurrence locally? Is that metastasized? Like, what are we missing? Like, it feels like we're missing something here.
Oh yeah, I don't know, Betsy, do you want to take that answer?
I was like, that is the question that many of us here at UCSF are dedicating careers to. There have been like large iterative clinical trials run through the COG trying to like either escalate or de-escalate therapy for certain subgroups, and positive signals just haven't resulted. There's actually an open trial right now though, so it's including like a tyrosine kinase inhibitor in addition to like multi-agent chemotherapy.
Yeah, and also no one dies of a tumor in their leg, so it's always that it metastasized. And interestingly, about 20% of patients are presenting with micrometastatic disease. So we can't even, 20% are presenting with metastatic disease, and everyone is probably presenting with micrometastatic disease. So even though everything looks good initially, you may get, you'll see a metastatic recurrence.
But yeah, that slide is the first slide of many of us about why we need to do better for osteosarcoma.
We have is about nanos.
Yeah, so yeah, I think because infection is such a big problem for us, there's been a lot of work in trying to determine if you can coat the implant with some sort of antibacterial surface. So there are a couple implants out there that are coming out that will have betadine coating. And there's an implant in Germany that has a gold coating and silver, which can also be antibacterial. But that is an area right now where all the implant companies are trying to figure out a nano coating that's going to be antibacterial. And the big problem, the reason why this is such a big problem is when an implant gets infected, the bacteria create what's called a biofilm. And so they cover themselves, and there's no way for the antibiotics to get, you have to get the implant out. There's just no way to, you can't scrub it clean, you can't do anything. So it would be trying to create a biofilm disruptor so the bacteria are never able to form the biofilm.
So on the other side, sorry, go ahead, Mike.
I'm wondering if there's any difference in incidence of infection for the ones we have to physically go in and turn the screw versus also this magnet have.
Yeah. Yes. So getting an MRI with the magnetic expandable, like you have to sort of do a whole protocol around that. Also, though, I will say MRIs are not very helpful in these patients because just the metal artifact, you just can't see anything anyway. So it's not very often, but that is a problem. And yes, the rate of infection is less with the magnetic than with the open. So in our paper, of our 36 patients that had distal femur expandable, the first generation of that implant required a larger incision, not the 1 centimeter. And the rate of infection among those patients was about 50%. So it's really correlated with opening, exposing the implant to the environment, and length of the incision.
So Serene asks, are there any ways to make the implant itself immunogenic or for it to?
Such a good idea. I could put you in touch with some, the question was, is there any way to make the implant itself immunogenic or secrete cytokines? Or otherwise. Again, as where we are now is trying to create a surface coating that is antibacterial and disrupts or prevents biofilm. I love your idea though. I mean, that's good. Yeah, it's a great idea.
When you say 800 pounds of force, that sounds really painful. Can you help me wrap my head around it? Or just explain, like, I might not be able to wrap my head around it, but like how that isn't actually painful for the patient?
Yeah, I think it gets like we just cut their leg open, you know, from here to here, and then cut the bone and took a bunch of muscle. So it's not like there's no signal that's not going to rise above the signal of everything else we just did. But it doesn't appear like when you load the bone like that, that doesn't appear to cause actual pain because it's the way the bone is meant to absorb. You know, if you have a shear force or if you have a rotational force, that's much more painful. But this is just like kind of axial inline loading. And the bone pain typically comes from irritating the periosteum. And this is just kind of going right through the cortex, which doesn't seem to have much of a pain receptor. But I would guess that the bulk of the pain patients are feeling in that perioperative period is from everything that was removed. Yeah.
What happened?
He says they did great. And he never wrote it up, which is frustrating. So it's all like, I mean, he told me this story many times, you know, and I kept trying to see if he would give us the data, you know. He did a really interesting study here, though. You guys might find this interesting. So he worked with some of the immunologists here, and he found, like 7 patients that had osteosarcoma, and then he drew blood from their family members. And he found that their family members seemed to have antibodies against antigens that were found on the patient's osteosarcoma. And he called this transfer factor. And so then they actually sort of harvested the blood, the antibodies from the family members, and injected the patients with this transfer factor. And those patients had a much better survival than historic controls. This was published in like the late 70s. I can give you the paper. It's pretty interesting. But that immunity wore off. So then when patients were cured of the osteosarcoma and they sampled the family members again, they didn't have any long-term immunity to the antigens on the osteosarcoma. So he did some real work and some questionable work.
Thank you so much.
All right, thank you.
I think I just want to